Bismillah ar-Rahman ar-Rahim. I have the pleasure to meet you today. Today we are going briefly to discuss the management of ingested foreign bodies in pediatrics. I am Professor Ahmed Megahed, Professor of Pediatrics, Mansoura University Children's Hospital, consultant PGI, Hepatology and GI endoscopy. Our objectives today is a simple introduction about the magnitude of foreign body ingestion. Is it a real problem and a real challenge or not? Then, to illustrate some of the diagnostic challenges and pitfalls in diagnosis of foreign bodies. And to set up a management plan to focus on the annoying foreign bodies and to discuss further complications and even complications of management. Foreign bodies. Foreign bodies is really a common clinical problem in young children. Young children explore the world with hands and mouth as well. And fortunately, most of the foreign bodies does not cause harm and spontaneously come out the rectum without treatment. الحقيقة إن الانسيدنس is not well established in Egypt. الأرقام دي is USA figures. It is almost more than 100 patients annually in the USA. أكثر من 80% occurs in pediatric population, and 98% of these foreign body ingestions are accidental. The majority of foreign bodies reach the stomach will pass spontaneously through the GI without consequence. This is the majority, but still, endoscopic retrieval is indicated in 10 to 20% of these foreign bodies, and in less than 1% of ingested foreign bodies, surgical intervention may be required. What are the diagnostic challenges and pitfalls in diagnosis of foreign bodies؟ هل فعلا الموضوع بهذه الأهمية ويستحق إن احنا نتعرض له بالذكر؟ حقيقي إن in almost 40% of ingested foreign body there may be no history of witnessed ingestion. ممكن الطفل ياخد الفورين بودي من غير ما حد يلاحظ ولا يشوف. دي أول صعوبة في التشخيص في 40% من الحالات. الصعوبة التالية most of gastric and 20 to 30% of esophageal foreign bodies are asymptomatic. يبقى 40% unwitnessed, majority of cases of gastric foreign bodies and almost 1/4 of esophageal foreign bodies have no symptoms. الصعوبة الثانية إن الexamination is uneventual. No physical signs. If you have physical signs, this equal complication. And the complication could be airway problem, to have a problem in the airway, respiratory difficulties, because of compression of that foreign body, or in the esophagus it can compress the trachea, or abdominal complication because of penetration, perforation, and it can lead to perforation and acute abdomen. Radiology. The radiology is of a big value. It is important for localization of the foreign body, نحدد مكان الفورين body, exclusion of complication, that there is no air under the diaphragm, for example. But again, there is some challenges in the radiology. We have radiolucent foreign bodies like plastic and the glass, and the use of dye studies is not preferred because it will defer the endoscopy. This is an example of unwitnessed ingestion of foreign body. This is a 7-month infant presented with hematemesis. She had been admitted for almost 7 days the condition persists, endoscopic assessment reveal unwitnessed foreign body in the duodenum, a bin in the duodenum. This is an example to show you that sometimes the foreign bodies can cause unrecognized problems and needs to be in your mind in the differentials. Missed foreign body. This is a 4.5 years old girl presented with 6 weeks of progressive dysphagia and recurrent cough and drooling that can point to an esophageal problem. Unfortunately, she had improper X-ray. The proper X-ray, the proper film to evaluate for foreign body should involve, you should write it like that: neck, chest, abdomen, and pelvis, AB and lateral. The physician ordered chest X-ray, the initial chest X-ray. The neck was not imaged, so he considered it free. Repetition of the X-ray showed acquion impacted in the esophageal, in the cervical esophagus for almost 1 month. And this is the situation on endoscopy. A stricture formation, stenosis, ulceration, and hardly we could retrieve it without complication. So this again is one of the challenges, the neglected foreign bodies, because of unawareness about its magnitude. Airway problem. This is another 6 years old child that had been presented with progressive stridor, no history of fever. Currently, there was a history of some fever at the onset of the disease, and he was presenting almost 3 weeks after the onset of the fever and the stridor. Of course, the stridor is an airway problem, upper airway problem. He was assessed by bronchoscopy. During bronchoscopy, the trachea was seen to be compressed from posterior, so he was referred for us to assess the esophagus and if there is an esophageal problem or not. This is how he looks in endoscopy. The upper esophagus was difficult to intubate and slit-like with bulging posterior wall. And this is his radiology. You can see here that there is something odd here. This was a fishbone, and this is a collection. This collection is retroesophageal. He had a retroesophageal abscess because of that fishbone that had impacted there and caused respiratory problem. This is one of the unique videos. She was a girl that was playing with a mouth, with a pen in her mouth, and she folded on her face and she swallowed the whole pen. Of course, this is a radiolucent. Just the metallic tip of the pen could be traced in the radiology. But the history was clear. The parents were witnessing the event. Another example of difficult to diagnose foreign body is the radiolucent foreign body. This is a plastic part of a toy, and you can see that its edges had lacerated the esophagus completely, and it was about to perforate. Another challenge is the radiolucent foreign body. This is a piece of glass. The glass could be visualized in the CT, not in the X-ray. And it is in the upper esophagus, and it could be retrieved. So, we have challenges in diagnosis. Many of the foreign bodies are unwitnessed, up to 40%. Almost all gastric and 1/4 of the esophageal foreign bodies is asymptomatic. We have limitation for the radiologic diagnosis. the radiolucent foreign bodies, like glass and the plastic metals. In the radiologic assessment, you should always be sure where is the foreign body. The localization should be definite. What is your opinion about this foreign body? رد علي. ايه رأيك؟ شكله فين؟ شكله في السtomach. It seems to be gastric. I agree with you. We have to take a lateral film as well, okay, in order to see if it is gastric or in the transverse colon. Moreover, the clinical context, this was actually referred to the endoscopy unit as a gastric foreign body. The history that this 12 years old child had fallen on his back on a sharp object. You can look to the CT. This is a metallic object in the back muscles. It is not related to the GI at all. So before going for endoscopy, you should be sure that this is a GI foreign body and it is within your reach. It is still luminal. It is still within your reach. It is not small intestinal, for example. This is another example. Again, could you help me? It looks where? It looks in the descending colon on the cecum, okay? If the body is present in that place for almost 4 weeks, you have to suspect he is in the most roomy, in the roomiest part of the GI. He should go forward. You should suspect extraluminal migration. He actually had perforated the cecum and he is in the peritoneal cavity, not in the lumen. The management planning. We have discussed actually the challenges, so how to manage this problem. This is a question, Hamlet question, to be or not to be. That is the problem. Remove or not to remove, that is the problem. When to remove foreign bodies. This is the most important single slide in that presentation. Foreign bodies requiring endoscopic or surgical removal are the annoying foreign bodies, large enough to cause obstruction, and by large enough, more than 5 centimeters in length, if it is cylindrical. If it is something like coin, rounded object, more than 2.5 in diameter. Sharp foreign bodies. A foreign body that can cause transmural injury, like disc batteries. Multiple magnets, because multiple magnets adhere to each other, incarcerating in between some of the bowel walls. And by mechanical force, pressure, necrosis, and perforation occurs. You may have a foreign body in the distal ileum, a magnet in the jejunum, and the distal ileum becomes stuck to the jejunum. And by pressure force, pressure, necrosis, and perforation. And a new threatening toys in the market, the water absorbent beads. لها اسماء كتير واشكال كتير وشكلها شكل الجيلي وشكل الكانديز. It has the power to increase its size 400%. الحمد لله احنا ما بيجيناش الانواع الكويسه، احنا بيجينا اللي بتكبر حبه صغيرين، انما في حاجات 400 double its normal. So it could start from 1.5 millimeter, it will reach 6 centimeter. And there are reported cases of small bowel obstruction and surgical intervention because of this beads, water absorbent beads. And esophageal foreign bodies. These are the foreign bodies that needs intervention. The timing is crucial. Rule number 1, do not allow any foreign body in the esophagus and do it as early as possible. And it is emergent retrieval, emergent that I have to do it at once. No time to wait. Apart from preparing the patient, some waiting for if he is not fasting, something like that. Sometimes we insert a cuffed endotracheal tube and do not wait even these 2-3 hours. Okay. Look for this. This is different from the radiology of a coin. It looks to have a double contour. This is a disc battery. The disc battery, the difference between the disc battery and the coin in the radiology, the double contour. This is a disc battery in the esophagus. Or sharp foreign body in the esophagus. This is a safety pin in the esophagus. Or any foreign body causing esophageal obstruction, either food bolus or any material that can cause esophageal obstruction and drowning. This is an emergency retrieval. Otherwise, it is urgent. You can wait for almost 8 hours. If there is something in the esophagus like coin without obstruction, you can do it as non-urgent endoscopy. Or if you have object in the stomach with diameter 2.5 centimeter or less, or if you have disc or cylindrical battery in the stomach, you can wait in the stomach up to 48 hours. Okay, so if you have suspected foreign body, if it is esophageal, consider endoscopic removal immediately if it is disc battery, sharp foreign body causing impaction, or in 8 to 12 hours if there is no manifestation of impaction or asymptomatic in the stomach. If you have symptomatic or sharp foreign body more than 2.5 centimeter, you can remove. This is non-urgent situation. If you have blunt or sharp foreign bodies less than 2 centimeter, you can follow up almost 4 weeks. A coin in the stomach can be followed almost for 4 weeks, except for disc batteries, the maximum is 48 hours. If the foreign body is distal to the duodenum, it is out of the reach of the endoscopy. Do X-ray weekly, follow up for signs of intestinal obstruction. If it is a battery, again, the battery is not allowed to be for more than 48 hours, except in exceptional situation under close supervision. These are some of the endoscopic retrieval tools. One of the important issues in foreign body retrieval is to take care of the airway, either through an overtube or endotracheal intubation. The annoying foreign bodies, the multiple magnets. You can see here that this kid had ingested 6 magnets, and this is how he looks. Multiple magnets is an indication for surgery. He had perforation in the intestine, in the posterior gastric wall, in the mesentery. Disc batteries can cause drastic complication. There is a major campaigns against disc batteries. In the last World Congress of Pediatric Gastroenterology and Hepatology, there was a 3-hour committee for disc batteries management. It is still a major problem. It can cause injury by electrical pressure and chemical insult. It can result in perforations, fistulae, stricture, and rarely toxic absorption. This is an example of an esophageal severe burn from a neglected disc battery for almost 2 days. This is a case of multiple disc batteries ingestion. You can see that here there is air under the diaphragm, a perforation, and she had developed pelvic collection, and she needs to fix a drain. By the way, this girl was from Bursaid, and she was the only girl that we have seen suffering from toxic absorption. After her management from the toxemia, she had been managed by the surgical team. She continued to suffer some lethargy and some CNS manifestation. Toxicology screening revealed that she is intoxicated with mercury, and she required bowel treatment. Mercury disc batteries had been abandoned from the European Union. They are still present in China. Most disc batteries are lithium, and it had been intoxicated with mercury secondary to disc battery ingestion. One of the recommendations for disc battery ingestion for the GBs is the use of honey. We can use honey, 10 milliliter, 6 doses, 10 minutes apart. This will coat the disc battery, preventing the alkali injury and the thermal and electrical injury. It should be administered very early, immediately, not after the first 6 hours, because after the first 6 hours, there is a possibility of already being perforations and complications. Safety pin is again an example of challenging foreign bodies and sharp foreign bodies that can cause perforation. Even this is a pin that had perforated the antrum of the stomach, and you can see it in the CT. This is the message, and our mission is to raise the awareness and to promote the preventive activities and the strategies. Worldwide, there is campaigns to raise the awareness about the disc batteries. Take a charge of bottom batteries around your home. Even the industry, the new industry, the toys, they are replacing the simply put batteries that you can open its slot and take it off by something like, you know that only in supermarket chains, you have to insert a coin in order to get it out, a slot to insert the disc battery in order to get the one inside out, in order to prevent any child from non-intentional ingestion of this battery. The same is applied for acoustic injury. In another session, we are going to discuss the acute acoustic injury. Also, the use of public media for announcement about the cases you have seen and the danger of that problem. The social media, posting this information is important for raising the awareness among the community and among the pediatrician community as well. So finally, we have to have high index of suspicion. We have to properly localize the disc battery, the foreign body position, and we have to decide wisely and intervene timely and cautiously. We have to anticipate complication, and remember, do not leave any foreign body in the esophagus. Remember the annoying foreign bodies, the sharp foreign bodies, the multiple magnets, the adsorbent beads, the disc batteries. Thank you very much, and I wish it had been of some use for you. Thank you very much. And these are my contacts, and feel free if you need to contact me in something like that.